Well, hello, it's Mrs. White, and today we're going to have a lecture on stroke, also called cerebrovascular accident. Okay, so let's get busy with this. All right, going back here, sorry about that. All right, so strokes occur when there is ischemia or a hemorrhage in the brain. It's also called a brain attack, a CVA. Basically, blood is supplied to the brain by two sets of major arteries, okay? We have the ICA, which is the internal carotid arteries, the MCA, which is the middle cerebral arteries, and the anterior cerebral arteries. Now, each one of those arteries feeds a different part of the brain. So the MCA and AC, they feed the frontal, parietal, temporal, basal ganglia, and thymus and hypothalamus. So what does this mean for us? It means that the signs and symptoms we see will be based on which part of the brain has lost blood supply. All right, so blood supply accounts for 20% of cardiac output, and any alteration in the blood supply to the brain can cause death in as little as 5 minutes. And the amount of blood that's available to the brain is affected by things like systemic blood pressure, cardiac output, and blood viscosity. When it comes to cardiac output, an interesting fact to note is that it takes up to 33% reduced cardiac output for the brain to be affected. And again, that's because the body is really good at harnessing the blood supply from the periphery and putting it to the vital organs. All right, so remember that carbon dioxide is a potent vasodilator and can have a really dramatic effect on cerebral blood flow. So increased CO2 means increased cerebral flow, and decreased CO2 means decreased cerebral blood flow. Intracranial pressure influences blood flow as well, and as intracranial pressure increases, it decreases the cerebral blood flow. So that's why it's so important to the care of the patient with a stroke. All right, so stroke, of course, is a leading cause of death in our country, so the fifth most common cause. Basically, there are a lot of sequelae. The people that do survive, they have permanent disability, up to 30% of them. So this is a big deal for us, okay? Especially because it's pretty preventable. All right, so risk factors. Something to note is that more risk factors means more risk. And some cannot be controlled. Those are non-modifiable, while others can. So some of the risk factors we have are age. The risk of stroke increases with age, and 2/3 of strokes occur in those who are over 65. More common in men, but more women die. African Americans have double the risk and are more likely to die of a stroke. Hispanic, Native Americans, Asians have a higher incidence than Caucasians. There's a family history, and this may be due to genetic variations in lipid metabolism and other things. So right there on your left side, that's what you have are non-modifiable, right? You can't change your age, your gender, your ethnicity, or your family history. But what you can change is on the right. Those are considered modifiable. So hypertension is the most important risk factor for stroke, and proper treatment can reduce strokes by up to 50%. So the goal for hypertension is to have a systolic blood pressure less than 140. Under heart disease, atrial fibrillation is responsible for 25% of all strokes. This is a big deal, guys. Anybody with atrial fibrillation needs to be on anticoagulation. Some other issues might be myocardial infarctions, cardiomyopathies, valve disorders, and patent foraminal. Diabetes, 5 times higher risk of CVA than the general population. Smoking increases the risk for both ischemic and hemorrhagic CVAs. And then some other things, right? Obesity, sleep apnea, metabolic syndrome, sedentary lifestyle, right? This is why we recommend 40 minutes of exercise 3 times a week. Poor diets, especially those high in fat and low in fruits and veggies, and drug and alcohol use. So let's try a question. It says, as one of your clinical assignments, you're assisting an RN with the health screening at a health fair. Which person is at greatest risk for experiencing a stroke? I want you to go ahead and read the choices. Make your selection. Press pause right now. And when you're ready, unpause me and we'll see where you get. All right, so this is the answer. It's a 62-year-old black male with hypertension who's 35 pounds overweight. Right, this guy has 5 risk factors: his age, his race, his gender, he's hypertensive, and he's overweight. Remember, the more risk factors, the more at risk the person is. Okay, so a TIA is the actual name is transient ischemic attack, but often we call them TIAs. Basically, it's ischemia without infarction. It's a transient episode of neurological dysfunction that generally lasts for less than an hour. It's more than likely related to microemboli that are cleared and then moved. But again, it's a warning shot of a stroke. So there is something called the ABCD score, which is used to predict the risk of a stroke after a TIA, including age, if their age is over 59. Their B is for blood pressure, so if their systolic is greater than 140, diastolic greater than 90. The clinical features, so weakness with or without speech impairment, and then duration, whether it's more than 60 minutes or less than that. So again, and also whether or not the person has diabetes. So the higher the risk or the higher the score, the more likely they need hospital care. So at the end, though, there's really no way to predict the outcome, scores or not scores, but we do know that many times folks who have ischemic attacks go on to have embolic strokes. All right, so let's continue on to the different types of strokes. So there are 2 different types. There's the ischemic, which can be thrombotic or embolic, and then the hemorrhagic. The thrombotic stroke is the most common stroke. It's basically thrombosis at a narrowed atherosclerotic vessel. So you can see the picture there. The person has a very narrowed artery, and then you get a thrombus there. A lot of times this is risk factors are age, hyperlipidemia, hypertension, and they are more likely to have had a TIA before. The embolic stroke occludes a cerebral artery, and as a result there's infarction and edema, and most are the result, let me just move us down here, most are the result of cardiac problems. A lot of times the patient with an embolic stroke will have sudden severe manifestations with little time to react. They may complain of a headache. They're usually conscious, and it occurs during activity. So that's what we would suspect an embolic stroke, if somebody's doing something when it occurs. All right, so we're going to continue on down to the Next slide. So this is a hemorrhagic stroke. That's an intracerebral hemorrhage. It's a bleeding due to the rupture of a vessel. Up to 80% mortality rate on a hemorrhagic stroke. The major cause is hypertension. But we'll talk about that in just a minute. Again, you have a picture here showing you it's actually bleeding into the brain itself, and the manifestation is a sudden severe headache. So if somebody has a complaint of a sudden severe headache, we would suspect a hemorrhagic stroke. All right, so bleeding into the brain caused by the rupture of the vessel, 80% of mortality rate. Major cause is hypertension, and another cause is anticoagulation use. So that is a big deal. Hypertension and anticoagulation. Again, they complain of a headache. Starts first sometimes with nausea and vomiting. They may have decreased level of consciousness. If you check their blood pressure, they are hypertensive. So that's what you have there, right? They have neurodeficits, headache, nausea, vomiting, decreased levels of consciousness, and hypertension. These are pretty dramatic. They can have progression, like you said, over minutes to hours. Okay, so subarachnoid hemorrhage. We'll move on to that next. It's intracranial bleeding into the cerebral spinal space. Now, normally the subarachnoid space is filled with cerebral spinal fluid. So if we use what we know from things like meningitis, which is a problem with the cerebral spinal fluid as well, we have the signs and symptoms here, which is the stiff neck and the focal deficits. Most are in the circle of Willis. So some of the risk factors for subarachnoid hemorrhage would include things like alcohol use, congenital abnormalities, and one of the big threats is cerebral vasospasm, which if it's to occur would be 6 to 10 days after the event. We end up with narrowed vessels that cause infarctions, and for this reason people are kept in the ICU generally for a couple of weeks to make sure they don't have cerebral vasospasm. And the calcium channel blocker, nimodipine, NIMODIPINE, that can reduce vasospasm. In order to give that medication, you must assess their blood pressure and pulse, and you want to hold it if their apical pulse is under 60 or systolic blood pressure is under 90. Because with subarachnoid hemorrhage, we would want to make sure that their blood pressure is over 90 and less than 160. All right, so cerebral aneurysm as well. This is, again, most in the circle of Willis. Many patients die. This is called a silent killer. Loss of consciousness may or may not occur, and again, very high mortality rate. And here's just a little graphic for you to see the different types of hemorrhage. So cerebral aneurysm and subarachnoid hemorrhage are sometimes used interchangeably. All right, so clinical manifestations of a stroke, they don't vary that much between ischemic and hemorrhagic, and it is the result of the destruction of the neural tissue. So things that are affected would be motor activity, which is the most obvious. So we'll go through some of these things, okay? So here's a little graphic for you about the left and right-sided damage caused by strokes. People who have right-sided damage tend to have neglect of their, spatial neglect. They intend to have more impulsive behavior, impaired judgment, while the left brain damage, they tend to have more language issues. I always think of left-sided language. All right, so motor function, again, is the most obvious. It is caused by destruction of the neurons in the pyramidal pathway. Those are the ones that pass through the spinal cord. And there's a contralateral effect. So the left brain affects the right and vice versa. The MCA artery, if that is affected, it leads to upper extremity weakness more than the lower extremities. Things that are affected are mobility, things like akinesia, which is impaired muscle tone. They might have hyporeflexia, then progressing to hyperreflexia. Respiratory function is considered a motor function. Speech and language. Remember, the language center is found in the left hemisphere. And aphasia may result. It's sometimes called dysphagia with an S at the end. And there's a couple different types. There's receptive, expressive, and then global. Dysarthria is muscle control of speech. It affects mechanical speech. And then we have the swallowing, the gag reflex, which gives us a high risk for aspiration, and self-care abilities, which means that we need occupational and physical therapy. So here's sort of what we were already talking about, some of the characteristics, right? Loss of voluntary movement is called akinesia. Changes in muscle tone. We just talked about that. Sorry, sometimes I'm ahead of myself. And again, we have an initial period of flaccidity, which can last up to several weeks. It's related to the nerve damage. And then spasticity tends to follow the flaccid stage. That's related to the upper motor neuron influence. Aphasia occurs when the stroke damages the dominant hemisphere of the brain. So that affects language. So in general, it is the left side of the brain. However, some left-handed people, their speech center is in the right side of the brain. So receptive is the loss of comprehension, expressive is the loss of the ability to produce the language, and global is the total inability. So my father-in-law, before he died, he had had a stroke that he had lived with for several years, and it did affect his speech. And he was able to understand you, but anytime he tried to talk, he could only say, "Tomo to me, Tomo to me." So what type of aphasia do you think he had? Hopefully you said expressive. He could understand us, but he could not be understood. So dysphagia is impaired ability to communicate. It's often used interchangeably with aphasia. So my father-in-law, he had a fluent dysphagia. So speech was present. He was able to say "tomo" to me, but he wasn't able to say anything else. Dysarthria, this is sort of that weakness. You'll notice that the people, as they're trying to speak, they become very tired. Gives them difficult articulation, phonation, so they might have a very soft voice. Means that you're going to have to really slow down for a patient who has dysphagia or aphasia. Ask them yes or no questions, sort of establish the communication in the basic levels there. Affect. Folks with strokes may have a hard time controlling their emotions. They may be labile and unpredictable. They may be completely exaggerated, and this can be magnified by what they're going through. the loss of function, the changes in their own self, and that can cause depression. As far as intellectual function, both memory and judgment can be impaired, and it also can impair their ability to learn. Spatial perceptual changes are more common with right-sided stroke, and that's because the parietal lobe affects self and illness perception, so they may deny their illness and not recognize their own body parts, and they would neglect the input from the affected side. And then you can see here that that's a picture of I can never say it, hymenopsia, which is blindness in the same half of the visual field in both eyes. So that really affects their spatial orientation. So if you see this person here, they're neglecting the entire left side. And so for that, we would want to assist them, put their food where they can see it, and assist them using the side that they can use. Agnosia is the inability to recognize objects using senses. I think of that as like I can't smell with my nose. I have agnosia. And apraxia is the inability to carry out sequential movements on command. As far as elimination, person may have bowel and bladder elimination problems. Most are temporary. They may suffer from constipation. So things that you might need to think about. If a person has incontinence following a stroke, in the acute phase, sure, you might need a catheter. You might need intermittent catheterization, externals, anything like that. However, that would not be good long-term care for a patient because of the risk of fur infection. And incontinence is not a reason to have a catheter. Retention is, but incontinence is not. So as the person progresses and they should be getting a little better, then we would want to make sure that we are using toileting schedules and all the things that we have at our disposal to keep people as continent as they can be. All right, so changing gears now. When a person is having a stroke or a suspected stroke, we have to figure out, okay, how are we going to diagnose it? And we do the studies to confirm that there's a stroke and figure out what type of stroke it is, because the type of treatment really does vary depending on the type of stroke. For example, if somebody was having a hemorrhagic stroke, it would be inappropriate to give them anticoagulation. So the CT scan, non-contrast, is what we do immediately. And don't get it twisted, even though it says MRI or CT, if somebody comes into the emergency department, we are not trying to get an MRI to see if they have a stroke. We're getting a non-contrast CT. And that CT should read negative if it's an embolic stroke. All right, some of the other studies that we might do are the CTA, which can visualize cerebral blood flow. So cerebral angiography is actually in through the artery and looks at the vasculature of the brain as well. Again, many of these are not stat. The non-contrast CT is the stat one, right? Non-contrast. Let me just go ahead and highlight that for you. All right. Some of the labs that we might draw would be the coagulation, CBC, electrolyte, lipids, and then looking at the kidney and liver function. Okay, so I believe there's a diagnostic studies section in your textbook that you can also look at. Let's go into interprofessional care. If we can prevent a stroke, we should. And these are all the ways to help prevent a stroke. This is the basis of primary care, especially as a person gets older. We want to prevent things from happening. So read through that list. Those are modifiable factors. All right, so preventative drug therapy, platelet inhibitors, we would use aspirin, 81 milligrams, that's most common for prevention. especially following a TIA. We would give high-dose aspirin, 325 milligrams, within 48 hours of the start of an ischemic stroke. Some of the other meds would be ticlopidine and clopidogrel. And just be aware that anybody who's on these antiplatelet medications would then need to let their providers know, and before they're having dental work or surgery, they may need to come off of them. And that they may also develop GI bleeds, peptic ulcer disease. So you want to make sure that the patient is aware of that and the signs and symptoms of GI bleeding so that they could report it. Surgical therapy would be interventions for the patient with TIAs. So one of the things, if somebody comes in with a TIA, we often do a carotid ultrasound because sometimes that's the culprit. And if that's the case, then we might need to do something for them, usually like a carotid endarterectomy, which is when they actually incise the artery and remove the plaque. There's angioplasty, when we use a balloon to open, and sometimes we leave behind drug-eluting stents with a little bit of anticoagulant in them. So you might have angioplasty, but it's generally angioplasty and stenting. There is something called an arterial graft, as they kind of replace a portion of the diseased artery. It's not something I've seen too much. Post-op care of the patient with any of these surgical procedures is very, very important. We want to make sure that you're doing a good post-op assessment, that neurovascular assessment. It is likely that a person could experience embolic stroke during these or shortly after the procedure, so you need to make sure you are monitoring them for that, and their blood pressure management as well, because they're at high risk for bleeding in the first 24 hours after this, and that could be whether they are doing like an endarterectomy, or if they were doing some sort of angioplasty where they're going through the arteries, right? So they could have a hemorrhage, because if you go through anything in the femoral artery going upwards, it can affect your peritoneum and the retroperitoneum. All right, so let's go now to some acute care of the ischemic stroke. Time of onset of symptoms is critical information. And for us, we always want to remember our ABCs, that if a person is unconscious, check for bleeding first, but otherwise it is ABC. The reason that time of onset is very important is because if they're going to be eligible for TPA, we cannot delay this, right? We need to make sure that we give it to them as soon as they can have it. All right, so baseline neuro assessment is here, monitoring for the person for increasing neurological deficit, and many people will worsen. Elevated blood pressure is common immediately after a stroke, and we do think that it's protective. So we do have some guidelines for ischemic stroke, which is we generally won't give them medications to treat the stroke unless their MAP is over 130 or the systolic's over 220. We want to make sure the patient's adequately hydrated. That promotes perfusion as well. And then manage their ICP. So using those interventions which we talked about under our other lecture on increased intracranial pressure to help with that. So TPA is the mainstay of treatment for this type of stroke. It's tissue plasminogen activator. It basically reestablishes the blood flow. Again, we don't want to delay. It must be given within 4.5 hours of onset of symptoms, or 6 hours for intra-arterial administration. But for our purposes, let's go ahead and say 4.5 hours. The sooner the better. Patients have to be carefully screened. The contraindications in our book are hemorrhagic stroke, recent GI bleed, a stroke in the last 3 months, any head trauma in the last 3 months, any major surgery in the last 2 weeks, and any recent bleed in the last 3 weeks. Person on TPA, we want to keep their blood pressure less than 185 for 24 hours. All right, so after we have stabilization of a stroke, in order to prevent further clots, we may treat them with anticoagulation. And again, they may have antiplatelets like the ones we've already talked about, or they may be on anticoagulation for things like AFib, where they would be on warfarin, or maybe some of the newer ones. And the use of statins is effective after ischemic stroke, so we'll definitely make sure our patients are on those. All right, one sort of treatment for it's endovascular therapy for a stroke is how to manage it, is that they could actually go in and get the clot. Sometimes they do that, sometimes they don't. All depends on the doctor and the patient. So again, they go through an artery, so your priority becomes the bleeding issues. And I do want to back up because I have some more notes. I just kind of wanted to mention a couple little things. When we were talking about the embolic stroke and about the intracranial pressure, but understand too that some other things can also occur. The person could be at risk for SIADH, so you want to avoid glucose and water infusions. And so what are our things that we do to manage ICP? It's just a reminder, right? Elevating the head of the bed, keep the head and neck in alignment, avoiding hip flexion, drug therapy, pain management, constipation. And intracranial pressure will generally peak within about 72 hours. But increased ICP is more common with hemorrhagic stroke. So it can be talked about under that. And to keep our blood pressure managed for our patient, we would use things like labetalol and nicardipine. But remember that we wouldn't treat it. I talked about different numbers we would treat and what we wouldn't. All right, so now we're moving along to the hemorrhagic stroke. All right, acute care for hemorrhagic. What we're going to do for those is, if we can, if they have an aneurysm, we can clip and coil it. We might be able to resect it. We could fix AVMs, or arteriovenous malformations. As you can see here, that's a picture of a clipping. So if they clip it off, it means that even if it ruptured, it would not affect the vessel. And this is coiling. They thread through the vessel and insert coil in that takes the space and keeps the blood from being able to push against those weakened walls. All right, drug therapy for hemorrhagic stroke. Sometimes we will do things like I'm sorry, just had to look at something. We would do things to control the blood pressure because that is a risk factor for bleeding. We're a little bit more tight on our control. So basically we increase mean arterial pressure and cerebral perfusion by using those vasoconstricting agents. And calcium channel blocker nimodipine treats vasospasms and minimizes cerebral damage. So it's a drug we talked about earlier, but here you see it for your hemorrhagic stroke. All right, so let's do a question. Patients diagnosed with a thrombotic stroke. Over the next 72 hours, you plan care with the knowledge about what? Go ahead and pause, read through, and press play when you're ready. All right, and here we are, that the patient may show signs of deteriorating neurologic function as cerebral edema increases. Okay, so now we're going to run through some rehabilitation real quick for strokes, and hopefully that'll see us out of here. All right, once the patient stabilized for 12 to 24 hours, we then are moving from time to preserve life and to trying to restore function. Okay, so that's rehabilitation. And I lied to you guys. We're doing the emergency management. Again, I just wanted to make a slide for this. Uh, these are the core measures for stroke. So again, ABC, CAB, depending oxygen, if indicated, you want to do a neural assessment using the stroke scale, CT scan stat, and then the treatment is based on the scan. Okay, management of the respiratory system is a nursing priority. They're at risk for atelectasis, risk for aspiration pneumonia, airway obstruction. They may need to have mechanical ventilation. This is just the systems we're going through real quick. Neurologically, the patient needs to be monitored closely to detect changes that would suggest either they're having an extension of the stroke, increased ICP, they're having vasospasm, or what would be the best is that they're recovering from the stroke. You can just read this slide, but remember our goal is to make sure that we have good enough perfusion. We want to make sure we're correcting without overcorrecting everything. Cardiovascularly, what we do is we monitor the vital signs frequently. We monitor cardiac rhythms. We calculate I's and O's, adjust IV infusions. We also look at their fluid intake. We monitor the lung sounds for crackles and wheezes, which would be indicative of pulmonary congestion. We monitor their heart sounds for murmurs, and then we monitor for orthostatic hypotension before ambulating. As far as DVT prevention, after a stroke, a person is at risk just based on what's happening, and now they're going to be immobilized. But understand that we can't just give heparin and things like that. If a person's already on TPA, that's one thing. But all patients should be on SCDs, especially hemorrhagic stroke patients, right, if they can't have anticoagulation. Musculoskeletal system wise, we want to maintain optimal function and prevent atrophy. So you need to have physical and occupational therapy involved from the get-go. Skin, the person is at high risk for skin breakdown because of their sensation issues, immobility, circulation issues. So we want to make sure we are providing pressure relief, good hygiene, emollients to the skin, and getting them up and moving. GI system, constipation is the most common bowel problem. As we know, that can be very problematic for our patients with increased ICP. We want to avoid it. So we might use stool softeners, fiber, etc. The urinary system, we talked about this earlier, but make sure that we avoid bladder overdistension. We want to avoid catheter usage at all possible, so we want to get them on the toileting schedules as we can. Nutrition, very important for a patient recovering from a stroke. They may be initially NPO and then advance to a diet. If they do have a gag reflex, we do feed them. They may need altered textures. Definitely sit your patient up. They shouldn't be in the bed eating. In NCLEX hospital, we get every patient who's at risk for aspiration up out of the bed. Communication is very important to the person. Remember, they may have aphasia, so you want to speak slowly and calmly, using simple words. You might need gestures. That's why I put the little mime there. You might need to gesture to your patient and help them understand what you mean. Remember, the sensory perceptual problems are related to the hemisphere of the brain in which the stroke occurred, and it can manifest in different ways. And we've already talked about that a little bit. And again, patients with stroke on the left side of the brain, they're slower, they are more fearful. So these are the people who are going to be really timid and not get up. I mean, this is fake generalities, of course. But the right side, these folks are um, more impulsive, more likely to not think that they have an impairment. So left side, they do nonverbal cues, right side, verbal cues, right? Sit down. So question 3, patient has dysphagia. Before allowing him to eat, what did you take first? And you can read those and pause. Answer is the gag reflex, right? We have to make sure they have a gag reflex before they eat. Now on to rehab. Patients usually discharged from the acute care setting. They can go home, they can go to short-term rehab or long-term rehab. And basically, this goes back to how severe their stroke is and what their options are for rehabilitation after. We do know that if their muscles are flaccid several weeks after, then they're probably not going to regain function. So we want to prevent additional loss and then get them able to transfer safely and balance safely. It's not always possible. And then stroke survivorship, of course, their life is changed and they will need assistance, and their families may need assistance as well. And be prepared for the atypical emotional response from your patients. And use therapeutic communication to assist you. Family members must cope with 3 things that the neuro changes that they're seeing, they're not modifiable at this point. It is their responses to both the patient's loss and their loss. And when somebody first gets ill and they are being looked after, sometimes there's this dependency that can come, which you guys might be familiar with seeing. So we have to work very hard to work with the family to get them basically to let the patient do as much as they can for themselves and support the family through this. Stroke support groups are helpful, and they may be found in the rehab facilities or in the community. Sexual dysfunction, this may occur as a result of stroke, and it's just one more loss that they'll have to deal with. Again, there's a lot of resources available to patients after stroke. Anything from groups to Meals on Wheels to home therapy and different programs. So just be aware that you should be offering those. And the last thing to mention is the gerontologic considerations. Right? The fact of the matter is that strokes occur in the elderly, and it results in caregiver strain and issues for the patient for the rest of their lives. All right, guys. Thanks. Have a good one. As always, if you'd like to like or subscribe to my video, please do.